We're just going to keep going here. So I'm Michelle Niedens. I am the director of the Cognitive Care Network and a clinical social worker, and have worked in a host of settings, from hospital setting, from community setting, from clinic setting. There's probably nothing that I think is more important as we think through this dementia process as the necessity of a multidisciplinary team. And so we're going to have a conversation about that. We're going to look at some of the value added to that, how it in present day, how we see that constructed a bit, and ways we might adapt. So it is the direction, and we all know this as we look at increasingly different reimbursement models, especially being led by Medicare, that there is this recognition that dementia is a little bit of a different animal. At least chronic health conditions are a little bit of a different animal. And certainly when we think of those chronic and advanced conditions that affect thinking and cognition, that it's a different animal. So increasingly we see these models which integrate the reality that we have to deal with something more in individuals if we are to effectively serve them. So we see the rise of the CPC plus models in Medicare that really look at integrating primarily behavioral health, but also some other disciplines. We see nutritionists implicated as part of that, and the Medicare chronic care management codes. And some of you are in practices where you have chronic care management, and the service that provides as we connect people and deal with some of the not only social situations, but the connective pieces across providers. There we see value-based elements in Medicare replacement plans and Medicaid replacement plans, such as the PACE program and others. So even on the Medicaid side, on the state side, there's a understanding that healthcare requires addressing social determinants and other kinds of issues, and have embedded that in their privatization of those models. Integrated health education, we certainly see that at KU here at our medical school and others, where disciplines are sharing classes together, just that underlying of disciplines working together, and the forging of new partnerships as we see clinic practices in pharmacies, for example. So collaboration in healthcare is really not just sharing patients. It's really the process of problem solving and integrating different knowledge bases, different perspectives, and different pieces of the pie into that decision making. So it's the extension of an ability to carry out plans with dementia. Lots of the issues tend to be psychosocial related, tend to be behavioral related in terms of neuropsych issues and the emotional terrain of reacting. So when we look at different models for multidisciplinary collaboration, we look at essentially 4 different patterns. So one are co-located collaboration, meaning like the clinic in the pharmacy, or the behavioral health specialist embedded in the clinic, or the nutritionist embedded in the clinic, or the speech therapist embedded in the clinic. It tends to work best with non-hierarchical, meaning everybody is sharing in that decision making and has that component. Can be forged through shared consultations, so just relationships in which you're consulting across various locations, and it can be collaboration through referral and counter referral. Multidisciplinary team members range, and you see them listed here. All of these disciplines have something unique and something valuable to bring to the table. The most common of which we see in the current models are nursing, social work, primarily with behavioral health focus. So primarily looking at mental health diagnosis and pharmacy. But all of these disciplines have something important to share. And at times they're specialists, even within these disciplines. So research shows that when we think about collaboration and multidisciplinary team building, that it's stronger when it's face-to-face. So it's not just about the clinician having relationship with the patient or family, it's also about clinicians having relationships with each other. And so actually being in some sort of version of practice together seems to be the strongest in that shared space. And that doesn't have to be, full-time. It can be part-time, it can be spread out, but when there's shared space, face-to-face contact, that collaboration is the strongest. Accumulation of data also indicates is a indicator of strong collaboration. It perhaps is the toughest. When we talk about collaborations, most people have differing EMRs, for example, differing patterns of data collection and reporting. So that can be the biggest challenge, but is important for some data sharing when involved in these collaborations. Can be constructed in lots of ways. So innovation is part of that. It doesn't have to be straightforward. We all know the challenges of primary care. So we have all these competing priorities at play. Time is essential. We have volume-based reimbursement issues with essentially quotas in many situations to meet. We also face this issue of sometimes there's this belief that a diagnosis is harmful to individuals. When we think about dementia, that is not true. At least that is not true for the majority of people. So should not be a generalized assumption or conclusion that we arrive upon, but should be unique to the individual. Insufficient preparation for complications, especially around the neuropsych issues or the transitional issues. And that's where that multidisciplinary team is best. Habit, how we see it, general lack of resources when we're working with clients in the sense of, what does it matter anyway if we don't have a cure? And again, that's the reality is that when we focus on more functional preservation, there's a lot of hope. So hope should never be the question. We can make a difference. We can make a difference in the best possible way with that multidisciplinary approach. So dementia-specific needs. What makes dementia unique as it relates to clinic practice? One, there's a series of escalating losses. The loss is really not having Alzheimer's disease, for example. The loss is all the little things that go into that, the 47 losses that one faces in any given time period. And really having to deal with those unique losses is the only path forward for making a difference with these families. Changes to life patterns, and for some, the resilience and the resources are such that those changes can happen with relative ease, but for most people, these kind of changes are difficult. The increased risk of depression, if someone has a dementia, research ranges a bit, but it can be as high as 72% in individuals with a dementia have symptoms significant enough to be considered clinical depression, and it will look different. It will look like anxiety, it will look like irritability, it will look like negativity, it can even look like combative behavior. So it will look a little bit different, but those statistics are high. Late onset of alcohol abuse, we see that sometimes because of the depression, sometimes because of the boredom, as they lose the ability to participate in some of the activities they did before, or as a result of not driving. Sometimes it's simply they've had long-standing regular alcohol use and they've forgotten how many they've had, or their pattern has been changed because of short-term memory deficits. Relationships shift, and that's not just with patient and family, that's also across family members, where we see conflict and what I would consider fault lines in the family dynamic worsen in the wake of the stress and decision making that goes along with a dementia, loss of historical coping strategies. So I see lots of folks who perhaps have had a tendency to some dysthymia, perhaps have had a tendency to some anxiety disorders, perhaps have even been on the spectrum, but have managed well because of the coping strategies and the patterns that they've been able to sustain, that then become challenged and compromised in the wake of dementia. So superficial or absent disclosure of concerns. So people don't know exactly what concerns to bring up. Mostly when someone has a dementia, families and the individual themselves think, I'm just going to have to live with this. So they really don't bring the concerns to those of us in the clinics. So sometimes just even accessing information is difficult, especially if you're seeing the person and the family together. Sometimes the family will say, I don't want to make the person mad, so they don't give honest information. They set more silent. Sometimes they'll give us clues from behind the person, but all of those things can be challenging. The challenges in early detection because of the subtleties of that, and sometimes the flawed screening tools that we use that don't pick up some of those early changes. It requires an extensive assessment set that certainly primary care providers do not have time to gather, and really needs to be multi-directional, and then limited intervention options as it relates to medical treatment. That again, a lot of what happens and the challenges that occur on the psychosocial side. So there's a long trail of validated programs. So it isn't Michelle indicating that multidisciplinary teams are pretty critical in dementia care. It has been proven over and over and over and over again that there are significant outcomes that occur when we utilize this support. And these are some of the big studies that have come out over the years, the models for what we now look at in terms of integration of social supports. The Cleveland Managed Care Demonstration Project, which the outcome of that was reductions in depression, caregiver burden, and health-related costs. And very directly, there's an implication with fiscal burden in terms of the healthcare system. The PREVENT study was one of the most significant in correlating the cost of care with multidisciplinary teams. So they really focused on these mood and behavioral challenges and introduced care navigation, care management services, and measured through the MPIQ. And the results of all their study was, and all their services were, that when this multidisciplinary team approach was utilized, that a 7-point MPIQ reduction was experienced. And they were able to correlate that with healthcare. So for every point the MPIQ goes down, the neuropsych inventory questionnaire, it correlated to about $1,750 to $2,800 of savings per participant. Several years ago, the Alzheimer's Association, in partnership with some of the area agencies on aging, did a project called the Bridge Project. And we replicated many of the elements of the PREVENT study and really measured our success based on the MPIQ and the scores pre-post. And the Bridge Project reached an 8-point MPIQ improvement. And that was integrating social workers at the point of neuropsych crisis. The care ecosystem, it's a project we currently are working on in collaboration with OCCK as part of an ACL grant. But the care ecosystem was started in California and really looks at the care team navigator, which is in the care ecosystem is an unlicensed person who really does some of that entry-level data collection and then refers to nursing, social work, and pharmacy. Lots of it was telephone-based, and again, lots of positive outcomes. The dementia care management intervention, which doubled positive outcomes in the areas of service usage, caregiver confidence, and ultimately delays in institutionalization, which is really the holy grail with all of these support models. And then the Healthy Aging Brain Center in Indiana has been phenomenal. And again, you see the addition of care coordinators, one in RN, one in MSW, and the net cost savings in utilizing those resources. So generally speaking, when we look across multidisciplinary models, what are the outcomes that we see in a pretty unified way? We see improved physical, emotional, mental health well-being for individuals with dementia and their care partners. We see earlier identification of dementia. We see improved anticipation of deterioration of care, so less futile efforts occurring at end of life. What I would say, a clarity of a long-term plan with individuals with disease and their care partners at a time they're able to integrate some of those choices. Again, reduced and delayed transitions into residential and skilled care, which is vital as we see these healthcare costs go down. So reduced inappropriate hospital admissions, both acute and mental health, which also looked at readmissions in short proximity, especially on the Jerry Psych side, and improved communication between services, which probably was part and parcel to many of those outcomes. At KU, we work in a model of multidisciplinary supports called the Cognitive Care Network. And this is just yet another model with all those learnings of those other pathways. So it's a partnership with primary care. What we know is there are many people who cannot get to specialists. There are many people who don't need specialists. And who they trust the most is primary care. And so we partner with a set of primary care providers. We have about 20 practices we work with. We have approximately about 110 providers currently in our network. They go through some education through our Managing Dementia or Dementia Update course. Some participate in a series of pocket talks, as we're doing now, with key focus on diagnosis and disclosure, and some go through more abbreviated trainings online, looking at those elements. And in return, so they integrate some of our protocol, including early stage sensitive screening tools, and we place a social work navigator in their practice to see their newly diagnosed patients and patients that are having some challenges on a monthly basis. Again, the emphasis is on early detection, with this thought that, the earlier we get support services, the earlier we tackle in a multidisciplinary form, the better and stronger the outcomes would be. And the concept is shared resources. Let's be real. We none have the resources necessary for this onslaught of people with dementia. So we either work together or we fail individuals. That's the only two choices. We none have sufficient resources. That's true of our memory clinic. That's true of primary care practices. That's true of social work teams. The pathway forward is to figure out ways to pull our resources in a way that makes the most efficient sense. Integration of research opportunities. There are people that can get services through participation in research, and in those new cases of new diagnosis, people are very interested in what their options are from a research perspective. Sometimes they have available to them scans and other diagnostic options that would not be available in the general clinical world. We also have a couple of Zoom rooms, and that's an area where we're looking to expand, where we can have facilitated Zoom rooms for people who do not have that technology, who are not interested in technology, but would come into a congregate place to talk with specialists. So we periodically do provider surveys for our cognitive care network providers, looking at the benefits that they have seen in their practices. 60% of our providers say that because of their CCN partnership, they have seen earlier diagnosis, and that's primarily related to the training and the integration of the early stage sensitive screening tools. 100% have said it was helpful to have a practice-based resource, meaning the social work navigator, for their patients and families being diagnosed. 60% said better able to have conversations with patients, especially in early stage, regarding their diagnosis and changes. That's a tricky phenomena, especially with individuals who have not necessarily recognized those challenges, but the early stage screening tools have triggered a evaluation that substantiates a cognitive deficit, a diagnosis. 80% report benefit by patients. So patients have said to their provider that they have been helped by the dementia-specific navigator. And 80% of providers say it has reduced dementia-related questions that were non-medical to their practice staff. When people have the appropriate disease education and support, and we've managed some of the emotional terrain, the depression, et cetera, we see less calls in. So considerations when thinking through multidisciplinary integration, really looking at, what would best serve the given culture and practice, but part of that is identifying trends that can be derived through sometimes medical records, looking at what those challenges are, trying to find those commonalities where we see high time users, for example, and workflow processes that trigger objective disclosure. So one of those considerations is to really look at, can we integrate a questionnaire, for example, to care partners prior to them coming into their visit? Can we implement a survey when they're sitting in the waiting room before practice? So can we find a more objective mechanism that's reasonable and fits within our workflow to identify those needs? And then looking at community partnerships, does that mean sharing space in your practice as we do in the CCN? Our CCN providers allow us to see patients and families in their space. Sometimes it's just specialty area partnerships, forging relationships, for example, with behavioral health providers. Sometimes it is systematic information protocols. Just really looking at, you meet this criteria, and so we would like you to see or participate in this program. Shared education space. So there are clinics at times, or there are those of you who are in the aging professional world, to really look at shared spaces to provide disease education and information on a consistent basis. So even if you don't have a collaborator in your practice, that again, realistic basis, can community professionals and aging professionals, healthcare professionals come together to have a systematic training education program for families of people with disease? And then really looking at, is there a mechanism to facilitate telespecialist visits from your office? We have too many people who do not access services in that way. They want to come in, but they would come in, and if there were a Zoom, what we call our Zoom rooms in those facilities. So in conclusion, it's really I love this quote from Darwin. It is the long history of humankind that those who learned to collaborate and improvise most effectively have prevailed. And that's what we have to do with this, with the mounting numbers of people with dementia and the needs out there and the limitations that we all have. If there's questions, let me know. I'm looking at the slides. Yes, there's information on the CCN, and you can get these slides. That certainly is available. And if you have questions about any of the models that I talked about, just let me know. I'd be glad to talk with you further. Thank you for spending a little bit of time with us. Tina, I'll throw it back to you.
Thank you so much, Michelle. We always appreciate learning from you and hearing what you have to say. So thank you for visiting with us today. Again, we do have CE credit available. So that's at you can text the code 64CECA to the phone number listed in the chat. And if you need anything else, feel free to let me know. And we hope to see you next time. Thank you again, Michelle. We really appreciate it.
Have a good weekend, all.